agreement between clinical eye, dermoscopy, and histopathology with sensitivity and specificity rates exceeding 90% to be able to differentiate from benign and malignant lesions. And so, not just for dermatologists, but even for general practitioners and family medicine practitioners, primary care physicians. And so, dermoscopy can also predict histologic findings, which can, of course, aid us not just in the biopsy, but in the treatment options for skin cancer. So, skin biopsy still lies at the heart of management. It is the gold standard for the diagnosis of skin cancers. So, we're going to talk about just pigmented lesions tonight. Okay, so if a patient has a pigmented lesion, we look at the patient, we do history and physical examination, and then we use our dermoscope. We can use either a strong magnifying lens, Woods lamp, and of course our dermoscope. We can use any of the algorithms because we know that dermoscopy definitely increases sensitivity for skin cancers. And then we go on with our biopsy, and we'll talk briefly about the preferred methods of skin biopsy for these pigmented lesions. So if you have a lesion that is suspicious for melanoma, the most ideal biopsy technique is excision with 1 to 3 millimeter borders. We'll also talk about saucerization, shave, and punch biopsies. Or if it's a large lesion, you can do incisional biopsy on the thickest portion. And we'll also talk about the dermoscopic features that you can use to maximize your biopsy. So if your specimen is adequate, then you get a confirmed diagnosis, and then you can move on to the management of these cases. So talking briefly about shave biopsy for pigmented lesions, this is okay for superficial basal cells and also for superficial squamous cells or Bowen's disease. However, you can fail to see the underlying invasive patterns or even perineural invasion. If it's a broad shave that the clinician does, it'll have a scar and surrounding erythema that can make the border indistinct, and the tumor can then present as larger than it actually is. Although for shave biopsy, it's performed quickly, it costs less with less instrumentation. It does not require suture closure, and you can hemostase with either chemical cautery or just cautery itself. The disadvantage, again, of this broad shave biopsy is that it can have this big erythema and scarring that can look larger than the original cancer. Now, we can opt to do a central punch biopsy. So, in general, without dermoscopy, just punching the thickest portion of the tumor, the most darkly colored part of the tumor. So, Johan talked about the juiciest part of his lesion. For suspected skin cancers, it's either the darkest or the thickest part. Okay, so you can use a 2 or 3 millimeter punch at the center of the lesion, and this can show you both the growth pattern and the histologic subtype of the tumor, which can be either basal cell, micronodular, morpheoform, or infiltrative. This is better for the more aggressive growth patterns, and it ensures a small, definitive excision of the tumor and the most appropriate therapeutic approach based on histologic subtype. So the surgeon is therefore free to see the edges of the biopsy if you just take it from the center, okay? Now, curettage is not ideal. I highly discourage curettage. You may do this for superficial or nodular BCCs. Some of the most surgeons do curettage for debulking first or outlining the margins before they do the final excisions. But for biopsy, please do not do curettage. It really rarely allows for accurate assessment of tumor growth, and you will miss spiky tumor islands or aggressive underlying growth patterns, okay? So especially for the infiltrating morpheoform and micronodular BCCs or desmoplastic squamous cells, it has a lot of surrounding collagen, so I don't recommend the curettage. So let's start off with the first case. These are, so the cases I'm presenting are Filipino patients in skin of color. This was a 53-year-old Filipino female with a 1-year history of a dark brown bump, which gradually increased in size on the right forearm. And she said it was traumatized and was also bleeding at some point. So we can see these dark brown papule, well demarcated. Under dermoscopy, you'll see these arborizing telangiectasia on the surface, some white scale and micro ulcerations, and these dark blue-gray ovoid nists here. And true enough, it was a basal cell carcinoma when we did the biopsy. So dermoscopy for diagnosing basal cell carcinoma is very sensitive and specific. So sensitivity of about 91.2% and specificity of 95%. And compared to just clinical eye, so if you use your clinical eye, just a 67% sensitivity, it goes up to 85%. And the specificity using dermoscopy for basal cells goes from 97 to 98%. And it's usually better for the pigmented type, which is the most common type of basal cell carcinoma in Filipino skin, is the pigmented basal cell carcinoma. Now, there are about 20%, I would dare to say 40% of dermatologists who don't use dermoscopy. And I want to encourage them to use it because even if you don't feel like an expert, it can still make a big difference. As you use it, you will become more skillful, you will become more confident in your diagnosis, and then you will be able to also help patients because sometimes spotting a basal cell, Johan called it a spot diagnosis. Within 5 seconds, you'll see, oh, it's a basal cell. And then you can actually reduce anxiety for the patient if they're worried about melanoma as they wait for the biopsy results. So these are basal cell pictures taken from a local Filipino study here. So again, you can see the dermoscopic criteria for basal cell, the reticulated pigment network, which we only see in melanocytic lesions usually, the presence of arborizing blood vessels, which are these tree-like branching blood vessels, 52% sensitivity, and short fine telangiectasia you may also see. The large blue-gray ovoid nests, which correlate to these nests of basaloid cells, as well as multiple blue-gray globules, sensitivity about 60 and 38%. The leaf-like and the spoke wheel areas here are more related to superficial basal cells, so I would recommend that if you do a biopsy, do it on the blue-gray ovoid nest areas, okay? Try to avoid the ulcerated and small erosion areas, but those are also high dermoscopic criteria sensitivity. And Johan also talked about shiny white streaks and concentric structures, which are newer criteria for basal cells. Now, let me talk to you about precision biopsy with dermoscopy, okay? So in the US, in this study done abroad, they used both clinical dermoscopic and RCM, reflectance confocal microscopy, which I don't do. So I will not be able to explain to you RCM, okay? Just dermoscopy. So they use paper rings or paper stickers because paper stickers, they cover up the RCM. So the RCM person can just focus on the area of interest, okay? So just by using this precision biopsy, they achieve tissue conservation in about 100% of these patients. So let's take a look at this one. So this patient has a lesion behind the ear. Dermoscopy shows these dark blue-gray ovoid nests here, some micro-ulceration areas here, okay, and then some globules here and here, as well as telangiectasia here for this basal cell. They cover it with that paper tape, and then they only biopsy the blue-gray globules here. And sure enough, on biopsy, they see these beautiful, blue basaloid cells in islands, but it was a collision tumor with a intradermal nevus. So just by using RCM and this precision focused biopsy, they were able to identify that. Now this is another example. This is a basal cell. So they used dermoscopy to identify the telangiectasias. They covered it with the white paper, and then they used RCM, and they were able to take a targeted area with these small blue-gray globules here. And then you can see here it correlates exactly with those basaloid cells on histopathology. So moving on to case number 2 here, we have a 52-year-old female. She was a street vendor. This was on her right calf, and then she had no past medical history, a 5-year history of a mole on her right leg, mungo bean size, which increased in size, and then 2 months ago, she got an inguinal lymph node on her right thigh. She was given antibiotics without resolution, and then ultrasound showed this lymph node. And you can see this asymmetric lesion here with lots of blotches, a lot of streaks and streaming, some blue-gray, some blue-white veil here, and a typical network on this area here. So clearly it's a melanoma. Even clinically, you know that it's a melanoma. So these are the melanoma-specific structures that have been identified. So the greatest advantage of dermoscopy lies in increasing the pre-operative sensitivity of melanoma diagnosis. Remember, the dermoscope was created to diagnose melanomas. And clinical exam, just using our naked eyes, allows for a correct diagnosis in about 65 to 80% of the time. However, dermoscopy can push this up to 70 to 95% diagnostic accuracy. So just in general, the pigmented skin lesion biopsy is the most important intervention performed by dermatologists because early detection is life-saving in melanomas and determines prognosis. So we talked about that conservative excision, 1 to 3 millimeter margin for these pigmented lesions. For macular or flat lesions on the trunk or for lentigo maligna, You can consider saucerization, although, as I said, it can give you a very big scar. And if you want to do melanoma versus dysplastic, you can do saucerization with a 0.5 to 2 millimeter margin. And then if you do a partial biopsy specimen, it may yield a lower diagnostic yield. It may compromise accuracy in staging, but it is an excellent alternative when you can orient it along a skin crease. So for multicolored melanomas, you want to try to sample each color in the lesion. Okay, and so just looking at this study, it was a meta-analysis on thousands of melanoma cases. Dermoscopy done by trained clinicians improved accuracy of identifying melanoma from an odds rate of 16% with naked eye to 76. It's a massive, massive jump because you will see that disorganized pattern, and at least you will see at least one melanoma-specific structure. So with dermoscopy training, benign to malignant ratio decreased to 8:1. Okay, so this particular study by Avila looked at what are the most common dermoscopic features for melanomas that were thick. So for those areas, I would recommend, if you're just going to do a punch on the melanoma, look for the areas that will yield the thickest part. So for all melanomas, the dermoscopic features that you know are specific for melanomas is a typical pigment network, like here, a typical pigment network, the presence of multiple colors, or what they call the multi-component pattern, asymmetric blotches, which are these structureless black areas here, as well as asymmetric peripheral globules and dots. Now, for the in situ or the thin melanomas, the atypical pigment network is usually the most correlated one. But for invasive and thicker melanomas, you want to look for these things: atypical vessels, white scar regression areas, blue-white veil, which correlate to just masses and masses of these melanoma nests. And of course, shiny white structures, which are usually seen more in nodular melanomas compared to in situ. For invasive melanomas, you also want to look at the edges for radial streaming and blue-white veil. Okay, so whenever you see a higher number of melanoma-specific structures, it usually implies that that is an invasive melanoma. And again, just look for the atypical vessels, the scar white areas, the blue-white veil, and the shiny white structures. This other study by Williams said that irregular atypical pigmentation, the blue-white veil, atypical pigment network, and the multi-component pattern. So very similar, very, very similar, okay? And the structures and patterns on dermoscopy with the highest risk of melanoma when present were shiny white lines, pseudopods in the periphery, irregular pigmentation, and blue-white veil and peppering. So let's look at this melanoma here on the left side. These are some of the lesions that you can see as being melanoma specific. This area here with a pink circle is a regression structure. It's white. And then this orange triangle here shows a typical pigment network where the lines are not uniform. Some are thick and some are thin. This yellow circle shows atypical dots and globules, which are asymmetric in distribution. This area here shows streaks, and sometimes you can see also pseudopods here. This green line here is the negative network, which is not very specific, so you don't look for that. And this area here is the blue-white veil, which really has this bluish pigmentation and a glassy haze because of a very thick collection of melanoma cells. Okay, and you can see the sensitivity, specificity, and odds ratio on the right side. So for amelanotic melanomas, this particular lesion here looks like a keratoacanthoma. And you see that central crater, and then you see these hairpin vessels here, which seem to be surrounded by whitish structures, which are typical for keratoacanthoma. However, in this amelanotic melanoma, you will see pigmentation here. So you had a structureless gray-brown pigmentation here around the follicles, which was the lentigo maligna, as well as these strawberry milkshake area. So this milky pinkish background here with the atypical blood vessels is very typical for melanomas, especially the amelanotic kind. So dermoscopy can also help you determine which areas to biopsy for these particular lesions. This is another amelanotic melanoma, completely without pigmentation. And in these kinds of lesions, which are pink, and you don't know, is it a lymphoma? Is it a squamous cell? Is it a vascular tumor? Is it a melanoma? The best place to biopsy is the vascular pattern. So there's no pigment network here, no dots and globules. However, you will see a proliferation of these linear and dotted vessels, which are very polymorphous. And in amelanotic melanomas, this atypical vascular pattern is very, very high yield. And you can see here when they did a biopsy in that area, you can see these atypical melanoma cells just in this nodular distribution in the histopathology, okay? So dotted vessels, irregular vascular structures, especially if they're eccentrically located at the edge of the lesion, that's where you should do a biopsy. The positive predictive value for melanoma is about 90%. Now, let's talk about using the dermoscope preoperatively, intraoperatively, and postoperatively for the surgeons in the room. This is a study by Jawed identifying the biopsy site prior to most micrographic surgery using dermoscopy. So most surgeons may have difficulty identifying the tumor site and biopsy scar clinically despite inspection, assistance from the patients and families, photos and diagrams with distance measurements. And this can be because the initial tumor was small and completely removed. The biopsy site is no longer visible to the patient and they're unable to identify the surgical site. There's a long delay, like months, between the initial biopsy and the final definitive surgery. And doctors can make mistakes in identifying the biopsy site about 4.4% of the time. So these mistakes can lead to wrong site operations, patient dissatisfaction, and further surgery. So there are 3 clues, okay, to identifying the biopsy site prior to most surgery using dermoscopy. 1, you look for the scar, which looks like a homogeneous pink patch accompanied by a cluster of small caliber vessels, okay? So you may not see chrysalis or shiny white lines, which are the collagen and fibrosis, if it's an early scar. So you will just see a homogeneous pink patch with some blood vessels. Secondly, you can see the boundary between the scar and the surrounding normal skin. So it can look like a hypopigmented or pink patch between the scar and surrounding skin. And third, you may also see remnants of non-melanoma skin cancer like the basal cell. So a small blue-gray ovoid nest or some other basal cell specific structure. So here is the biopsy site. It's hard to see where the lesion is, but here you can see this pink patch here, this homogeneous pink patch with some blood vessels, and in fact, this tiny blue-gray ovoid nest here where there was a remnant of basal cell left behind. So this is the biopsy site where they're gonna do the Mohs, and this other patient here, this was 1 month after the biopsy site healed. You can see the outline of the scar here, which is hypopigmented and a bit different from the surrounding normal skin. Okay, so again, here are the 3 clues. You can see remnants of basal cell, you can look for the scar, and the hypopigmented demarcation from surrounding normal skin. This is dermoscopy guided excision of basal cells for, I guess, for institutions without access to Mohs surgery. What they do is they look at the tumor preoperatively. This is a basal cell. You can see the arborizing telangiectasia, the blue-gray ovoid nest, and some spoke wheel areas here. To determine the lateral borders before excision, they did 60 basal cells. All the treated tumors were completely excised, and they required no